I've been presented with X-ray frontal and lateral projection of left forearm, including the wrist and carpal bones. I'll take a moment to look at the findings. So this appears to be a skeletally immature patient. The physes are not yet closed. I can appreciate a relatively expansile lytic lesion involving the left distal metadiaphyseal region of the radius. It is not approaching to the articular surface and not crossing the physes or reaching the epiphyseal margins. It is causing significant cortical expansion. The cortex on the lateral aspect is significantly expanded with an element of no, the cortex is expanded, but it's not eroded, and there's significant overlying soft tissue swelling. The ulna, it has got a narrow zone of transition without any evidence of any periosteal reaction. The carpal bones appear normal. I can also appreciate another lytic diaphyseal medullary lesion involving the proximal ulnar shaft with narrow zone of transition without any periosteal reaction, cortical break, or any endosteal scalloping. So for this distal radial lesion in an immature skeleton, my top differential would be an aneurysmal bone cyst. Since it has got an element of soft tissue swelling on the lateral margins, I'll be concerned for any aggressive conversion of aneurysmal bone cyst, and I would like to correlate if there is any prior relevant imaging, so that if I can compare if there has been any interval changes in the appearance, or if this soft tissue swelling and cortical elevation is a new finding. Also, I would like to know the history of the patient, if there is any acute pain or acute symptoms for this patient, that would also be concerning. I'll discuss my findings to the referring physician. Patient needs to have an MRI done in that case.
All right, madam. There are a few questions I need to ask regarding this case. Patient did present with pain, but he did have a swelling for a while. You talked about this case being an aneurysmal bone cyst. How would you explain this lesion then?
Aneurysmal, it is expansile with multiple internal
No,
septations.
madam, the
And
one
the
the one in the
Oh,
proximal
oh, sorry,
diaphyseal.
sorry.
Yeah.
Okay, I did not see your order. Okay, yes. So this lesion is noted on the lateral X-ray and faintly visible on the frontal projection as well. Um, I'm also
You said
suspecting
there
few
is
other.
you said there is narrow zone of transition. I do agree that most of this lesion shows narrow zone of transition, but what about the lateral aspect of this lesion? And
This
you said
area is
there
concerning. Yeah.
is no periosteal reaction. Do you think there is some periosteal reaction? Is the periosteum
Yes, when you have
elevated?
zoomed in, yes, I agree. I agree. There is some cortical elevation and this elevated Codman triangle kind of periosteal reaction in this area.
Okay.
Um,
So would you reconsider
Also,
your
I'm
diagnosis?
suspect. Yes, I would like to, because I'm also suspecting another lucent region proximal to the expansile region in the left radial shaft. So
Possible.
there are at
Okay.
least, yes, so there are at least, besides this larger lesion, there are two or three other lesions as well that I'm concerned for. Um,
So what would you do
okay.
next?
So I'll definitely concern for this patient, and I would like to further go ahead with MRI to look for the true extent of this lesion and its internal characterization, since they are multifocal, and since the other bone is also involved. So I would like to rule out a multiplicity of the lesions and the aggressive to confirm the aggressive nature of this lesion on MRI with
What do
contrast.
you think the probable diagnosis in this case is?
Okay. It can be. Mm, it can be a patient's. Can I please know the inflammatory markers of the patient if the
Normal.
normal? So this can be an aggressive bone lesion with multiplicity. I would be more concerned for any
An aggressive
metastatic.
bone lesion. Okay, metastasis in an adolescent male.
Yes.
What would be
I
the
would be
probable
at
cause?
this age, I'll be concerned for osteosarcomas, since this is a relatively an atypical radiological picture for an osteosarcoma, but the Codman triangle, the multiplicity, and proximal involvement of the bone is quite concerning.
What would you do next?
MRI. MRI for this lesion for the whole limb, including both joints.
All right. And all right, the lesion
Once
did
the
appear.
MRI is done, and if it proves out to be malignant, then I would like to get a staging CT chest done to rule out any distant met, and the patient needs to be referred to the sarcoma MDT for further discussion as well as biopsy from this mass lesion. So I've been presented with dorsal lumbar spine MRI T2 sagittal. I'll take a moment to see the images and then would start presenting my findings. Okay, so the patient looks to be of a younger age group. I can appreciate a well-defined extramedullary intense intradural extramedullary abnormal signal area, iso-intense to the vertebral body at the level of L4, L2. Yes, L2 vertebral body pushing the cord interiorly. Also, I can appreciate there is inferior, the conus is ending at the inferior level with uh, approximately at L4 level. Yes, there is some intramedullary elongated signals within the terminal lines of the conus. This might be a intramedullary T2 hyperintense signals. As I go cranially, I can appreciate some altered signals in the lower dorsal and upper lumbar region. I'm trying to locate its exact nature. These are mixed T2 hypo as well as hyperintense signals.
Mhm.
I'm trying to see the location of these signals, whether they are intramedullary or extramedullary in location.
There is a history of lower dorsal region surgery.
Surgery. I could also appreciate altered signals in the posterior spinal elements as well. So
Mhm.
these can be post-operative changes. However, I would like to confirm these on a pre-operative surgical scan, and I would like to know the history of the type of surgery that has been conducted. And also, I would like to see these areas of abnormal enhancement on T1 as well as post-contrast to check the enhancement pattern.
I'll show the post contrast sequence.
Okay, these are post-contrast images where I could appreciate the lesion that I was talking about in the upper lumbar spine is intensely homogeneously enhancing, pushing the terminal nerve roots interiorly. The lesion in the abnormal signal area in the dorsal lumbar region is demonstrating heterogeneously post-contrast enhancement with significant enhancement in the posterior paraspinal muscles as well. Uh, since there is a history of surgery, I would be concerned if this is an element of post-surgical infection. I would correlate my findings with any raised inflammatory markers. Also, I would like to check these areas of abnormality, especially the dorsal-lumbar spine on the axial post-contrast fat SAT images.
This is an extra axial lesion, right?
Yeah,
Okay.
extra.
Axial enhancing lesion. This was low on T1.
Yes, I saw on T2 low and intensely enhancing on post-contrast images, compressing the nerve roots anteriorly. So it's
Okay.
extramedullary, looks
Hmm.
like to be intradural without any lateral extensions into the neural foramina,
All right.
without any neural foramina
Okay.
extension.
All right. What do you
I
think
cannot
this is?
appreciate any meningeal enhancement with it in these specific images.
All right.
Neither I could appreciate that on sagittal post-contrast images. It can be a meningioma.
Okay. Is meningioma common in a young
Men-
in a
in a no, I
pediatric
feel
age
the
group?
patient is somewhere around second decade or first to second decade of age.
And meningiomas are not that common in that age group.
Not that common in this
Isolated
age group.
meningioma. So what would you consider them?
Might be in that
Can
case, I would be considering
can a
syndromic
patient?
abnormality.
Okay, this is what I wanted to
Yeah,
hear. All right.
yeah.
Yeah. Please go ahead. Continue.
Syndromic abnormalities as well. If there were multiplicity, as I mentioned before, that what was the surgery done for? This can be
It
another
was done
focal
for a spinal tumor too.
spinal tumor too. So it can be an element of neurofibromatosis. If multiple meningiomas, it can be multiple meningiomas or schwannomas.
What
Previously,
would
it
you do
can be
next?
NF2.
Okay, what would
I'll
you do
scan the
next?
whole neural axis, including the brain and cervical spine, to look for other lesions,
There you
especially
go.
the IAC. So I can appreciate some ventriculomegaly and hydrocephalus. There was an abnormal signal area. Um, yes. Okay. So this is abnormal signal area in the midline in the region of the lateral ventricles
Mm-hmm.
and foramen of Monroe.
Mm-hmm.
It is causing, it is associated with mild ventriculomegaly. Lateral ventricles are dilated as well as the third ventricles.
Considering the syndromic scenario, what do you think this
Yeah.
could be?
Okay. It can be low grade glioma with some enhancement around the optic
Are
chiasma as
gliomas
well.
common with NF2?
NF1. But
Okay.
the spinal lesions were more in favor of meningiomas and schwannomas.
So what do you think this is?
I'm sorry, I cannot fit that in
What would
into
you do
anything.
next, madam?
I'll discuss the findings with the referring physician. The hydrocephalus needs to be immediately conveyed to the referring physician, and pre-surgical imaging should be correlated with. And the case needs to be once the patient is stable, the patient needs to be discussed in neurosurgical MDT for management of this intracranial lesion as well as post-surgical infective changes of the spine.
And we are done. Now that we are off the pressure, what do you think this is?
Definitely an aggressive lesion in a
Definitely an
pediatric age
aggressive
for
lesion which mimics an aneurysmal bone cyst.
aneurysmal process. Hmm. So it can
Telangiectatic
be
osteosarcoma.
or spoke
Always consider
with
telangiectatic osteosarcoma when you're considering aneurysmal bone cyst. You
aneurysmal
did
bone cyst.
So your observation was good in this case. You described the lesion relatively okay, except for this part. There is elevated periosteal reaction here and here, and then see this soft tissue component. You did describe this was an important finding to see, possibly a lesion here too. Yeah. So the whole scenario becomes metastatic telangiectatic osteosarcoma. You were right with your clinical reasoning. You would refer this patient to the sarcoma center and you'd advise CT chest, abdominal, pelvis to look for any metastatic disease. So, with the observation, you're a pass in this case. With the knowledge, just pass, because eventually we did consider it to be an aggressive lesion, but I was not given the diagnosis of this case. Your safety management, it was a pass for me, and your communication skills are good. You speak very fluently. Okay.
Right, thank you.
With the second case, now again, madam, when you're off the pressure, what do you think this is?
Honestly, I'm not sure what the brain
But
lesion is.
this is a very uncommon location of a supratentorial ependymoma. And then you see an extraaxial lesion here, which was a
Yes.
meningioma. And then this patient was operated for another ependymoma here in the spine.
Mm-hmm.
Okay. So all of this becomes a neurofibromatosis
NF2.
2.
Mm.
And again, your safety management was a pass for me in this case because you did pick up on hydrocephalus. Your communication skills are good. Your observation is also good. You're a pass in observation too. You your knowledge is also good, but what you need to do is that you need to understand how to finish a case.
Hmm.
There was some lateral thinking required in both the cases. You did well with every aspect except for connecting the dots. Okay.
Hmm. Hmm.
Ependymomas, it's relatively uncommon to see ependymomas in the supratentorial location, but when you do see a meningioma here, try to put it all in one scenario rather than going here
Hmm.
and there, because eventually
Hmm.
the diagnosis of the case is going to be most likely one. It is very rare to see a case with multiple diagnoses. Okay,
Okay.
so it is most likely to be a single diagnosis in in your final exam. Not
Mm-hmm.
not a definitive rule, but a general rule. Okay, madam.
Mm-hmm.
So
Perfect.
this was a case of neurofibromatosis too. Thank you
Anecdote.
very much. All the very
Thank you
best
so
for your
much.
exam.
These are grayscale ultrasound images of the obstetric ultrasound, and these are focused on the fetal head area. There is septum in these images. The fetal brain parenchyma is not noted, and there is gross area of fluid density, which is showing anechoic appearance. And however, the fox and septum pellucidum are seen. Findings are suggestive of hydranencephaly. However, I would like to see other images as well.
Why are we saying hydrancephality in this case? We do see the cortical mental here.
Yes, sir. The cortical mental is here.
Hydrancephaly, you will not see the cortical mental. If the
Yeah,
cortical mental is absent, it's hydrancephaly. If it is present, then you differentiate between two other things that you
yeah.
need to check.
Hydrocephalus. Yeah, hydrocephalus and holoprosencephaly.
So what do you think this is?
Um, I can see that the fox cerebri is not complete, and
It is
it is
present.
absent.
It was
Yeah, yeah,
hydrocephalus.
yeah.
Okay, so what are you
Okay,
going to do
okay.
next with this case?
So because of the severe hydrocephalus, it can be due to multiple etiologies, like it can be due to any mass or aqueductal stenosis.
Mm-hmm.
I would inform these findings to the referring physician, and I would advise
Before
gynecological
informing these,
consultation.
before informing these findings, what would you do?
I would do I would complete the whole scan,
Yeah,
and
you would first
uh,
complete the whole scan, because when you see a hydrocephalus, you want to see a whole scan. You want to look for other abnormalities. You want to finish the whole scan. Okay, there you go.
yeah. Um, So, I'm looking at the images of the spine, and in the region of the lumbar spine, there is a defect noted in the subcutaneous region, suggestive of spinal dysraphism, and there is an inequate area in the lower lumbar region, as well as in the lumbosacral region, and this is likely a lumbar myelomeningocele, and putting all the findings together, it can be carried to malformation.
What would you do next?
Um, in carry to malformation, I would inform these findings to the referring physician,
Mm-hmm.
and uh, yeah, these patients need a gynecological consultation as well as neurosurgery consultation. There is large suprapatellar joint effusion,
Mm-hmm.
and So I'm looking at the PCL first. The posterior attachment of the PCL is intact. Now I'm looking at the anterior attachment where it is showing abnormal high signal intensity at the anterior attachment. And apart from that, the lateral meniscus is showing this high signal intensity, which is which is showing a vertical orientation and is returning in whole of the substance of the lateral meniscus at the posterior aspect. Now I am looking for the ACL, and no normal ACL is noted, so all the ACL is torn.
Anything
Um,
else?
in yeah, now I'm looking at the bone edema, and there are bony contusions which are noted in the distal femur as well as in the proximal tibia. And I'm looking at the muscles, and I'm looking at the vessels, um, which are unremarkable. And now I'm looking at the patella. Mhm. Which is in normal position, and the patellar tendon and quadriceps tendon are unremarkable.
All right. So what do you think this is?
I would this is traumatic knee injury in which there is ACL complete tear as well as
Okay.
partial tear of the anterior attachment of the PCL,
That's just
and as
magic
well as
angle artifact. The PCL is fine. What else?
yeah, there is vertical tear of the posterior horn of the lateral meniscus.
Okay. And the bone
And
contusions.
bony contusions, yeah. I would
Okay.
also like to see the medial and lateral collateral ligaments on the cornel view. Okay. So I will first scroll through all images and then I will describe my findings. So I'm first of all focusing at the medial and lateral collateral ligaments. Yeah, so the medial collateral ligament, it appears intact, and now I'm looking at the lateral collateral ligament. It is also intact, and rest I can again renote my findings, which I previously noted,
Mm-hmm.
that there is tear of the ACL in the intercondylar nodes. I can appreciate,
Mm-hmm.
and now I'm looking at the lateral meniscus, and I can again appreciate the high signal in the meniscus. Bony contusions I can again appreciate, and the suprapatellar vein. So I will urgently pick up the phone and inform these findings to the referring physician, and I would advise orthopedic consultation
Okay.
as this patient needs
All
management
right.
and
Is
repair.
there any particular name given to this type of injury?
Because there is injury of ACL, medial meniscus, and medial collateral ligament. I want to see again. Um,
We were done with the case. I just need to know if there
yeah,
is any particular name given to
yeah,
this kind of
yeah.
injury.
Unhappy triad.
All
But
right.
that also includes the MCL injury.
Okay. There was hydrocephalus. Yes.
Yes, sir.
Yeah, see, you could appreciate the cortical mental here. So it was not hydrocephaly, it was hydrocephalus, since you can appreciate the fox. And then when you see such kind of abnormality, what you want to look for is all the associated findings, for which you need to know the conditions which antenatally can cause hydrocephalus. All right, you did give me a few conditions which may cause hydrocephalus, which were fine, which were good. But before referring this patient or informing your findings to a clinical team, you would first want to look for the whole scan. So there was myelomeningocele, lumbar myelomeningocele. Yes.
Yes.
So is termination indicated in carry to malformation?
No.
No. So it was with the observation, it was a pass. You picked up on eventually picked up on hydrocephalus, and then the lumbar myelomeningocele was clearly picked up. Your clinical reasoning again, eventually the safety management communication skills are quite good. What you need to do is that you just need to calm down a little. Don't be too hasty. Let the examiner know that you know, and you do ask about the additional important images that you need. In this case, what you needed to say was to evaluate the whole scan rather than immediately referring this patient to any clinical team or department. Yes. So you would first want to complete the scan, and then you would communicate your findings to the other patient. So this was overall a pass case for me. With the second case, now can this is just a magic angle artifact. If I show you a T2, this will go away. So PCL is fine. ACL is completely torn. You rightly picked up on the tears of the posterior horn of lateral meniscus and the medial meniscus. What was important here was the bony contusions you see in the lateral femoral condyle and posterolateral tibial plateau. The when you see fluid signal on the outside and inside of a collateral, that is at least a sprain, even if you don't have
Yes, sir.
internal signals in it. So there was a medial collateral ligament sprain, and additionally, there was posterolateral corner injury. Can you see the popliteus muscle?
Yes, sir.
There is strain of the popliteal muscle and the tendon. It is
Yes,
one of
sir.
the component of the posterolateral corner injury. All these findings
Yes, sir.
together are called pivot shift injury. So just pass on the knowledge. Observation was a pass, clinical reasoning was a pass, safety management was a pass, and communication skills was a pass. Just read upon pivot shift injury. All right.
Okay, this is a frontal radiograph show of abdomen. Um, I can see there are multiple air fluid levels uh, of bowel. Um, the bowel loops are showing uh, appear prominent, and I'm looking for any like any features of obstruction in this. Mm, I don't see any intramural air or any string of bead sign in this, and no evidence of any free air in this. However, in the upper part of the radiograph, I can see there is a abnormal opacity overlaying the right breast, uh, which looks asymmetrical to me. The right appears to be the larger than the left breast,
That's
with
just
along
because
with
of
the.
the position. The patient is a little tilted.
Okay, okay, fine, sir. So coming to the abdomen, I can see bowel loops are prominent. Air fluid levels are not multiple air fluid levels are there. I suspect um, obstruction in this. However, I would like to see the entire radiograph to rule out any hernial obstruction or inguinal hernia.
Mm-hmm.
Then I would like to uh, I,
The
I would like
hernial
to know whether.
orifices were fine.
Okay, I would like to know whether the patient presented acutely, like with
The
acute
patient did
pain.
present acutely with pain and abdominal distension.
Okay, then I suspect uh, obstruction in this. As I can see, multiple air fluid levels.
Mm-hmm.
Um, However, I don't see any complications like free air. No evidence of
Okay.
pneumoperitoneum in this. The
Okay.
liver appears to be normal. No evidence of gas odor. So I would like to take this case further by doing a contrast CT abdomen
Okay.
to rule out the cause of the obstruction.
All right.
Okay, this is the frontal radiograph of pelvis with both hip joint. First, I would like to look for any abnormal sclerotic or lytic areas in this. Um, I I can see lucent area in the inferior pubic ramus with fairly well-defined uh, zone of transition and no evidence of any fracture, no evidence of any peripheral reaction over here.
Ignore that area.
And
Anything else?
okay, the hip joints appears normal, bilateral femoral head appears normal, no evidence of any cortical break in the femur, and I can see an area of abnormal sclerotic area near the lesser trochanter of left femur. Uh, this one, left side
It's just positional, nothing
position.
significant.
Okay, fine.
Yeah.
So in first instance, I didn't find any abnormalities. I would like to reassess the case once again. So bilateral iliac blades appear normal. The SI joints, I don't find any obvious um, features of sacroiliitis. Sacrum is fine. The visualized lower lumbar vertebrae appears to be normal, and the iliopectineal line on both sides appears to be normal. The sentence line are normal, and the
So nothing
visualized proximal,
significant.
nothing significant. Yes, sir. Yeah,
Patient presented with pain in the left hip region.
left hip region.
Yeah.
Okay. So I'm looking at the left femoral head. I'm looking for any sclerotic area or any crescent sign, subchondral fracture to rule out any avascular necrosis of femoral head in this. Mm,
Do you think
the
there is
joint
avascular
space.
necrosis?
Pardon, sir.
Do you think there is avascular necrosis?
Um,
Not really.
there are no obvious features.
Yeah.
The
Okay.
the femoral head appears smooth.
Okay. The patient has pain. What are you going to do next?
I would like to do take this further by doing an MRI hip, MRI pelvis.
You have the control, right?
Yes, sir.
Yeah. Please scroll.
So patient presented with left hip joint pain. So I would like to see at the femur first. The femoral head contour is maintained smooth. I'm looking for any uh, abnormal signals, any like double line sign uh, to rule out the avian, and is not seen in this. And there is no evidence of any joint fluid also. No evidence of a joint effusion.
Compare it to the right side. Do you think there's joint effusion
Minimal joint effusion I can make out compared to
on
even
the
on the
right?
right side also it is there. The right
Yeah,
side
but
also it is there,
yeah,
but
just stop scrolling for a bit. There is this pocket of
yes,
fluid you don't see here. Okay.
yes, sir. Yes, sir. Yes.
There is
Yeah,
this
yeah.
pocket of fluid that you don't see here. So say there is some joint effusion on the left side. The right is fine.
Yeah, double line
All right.
sign.
What would you do next?
Um, I would like to do contrast study.
You don't need to do contrast study. Just ask for a simple other fluid sensitive sequences to see any minor
Yeah,
changes here first.
star signals. I would like to see. Yeah, okay. In this star sequence, I can make out diffuse increased signals involving the femoral head and the neck of femur on
Mhm.
right side. On left side, there is also minimal left-sided joint effusion. No obvious contour deformity. Um, uh, so and no other abnormality in the rest of the visualized bones. To summarize my findings: minimal joint effusion with diffuse edema in the left femoral head and neck. The first differential I'm thinking of transient osteoporosis of left femur, um, left femur head, and second Uh, the second differential would be like, so I'd like to inform the findings of the referring physician. This needs to be like managed conservatively.
Mhm.
No further uh, or immediate management is required in this case, and can be followed if patient presents again.
So, in which age and gender is this condition common?
Mm, Middle-aged patients,
Male or females?
males.
Okay. Unfortunately, you did well except for one important finding that you missed, which is a red flag in FRCR. Can you make that out now?
Actually, I'm very poor in this regular sign. If it is there,
There was no regular sign. There is free
okay,
air here and here.
okay, here under diaphragm.
Yeah, air under the diaphragm here also and here also.
Mhm. Okay.
So, and this was acute small bowel obstruction with perforation, not without perforation.
Mm.
With the second case, you did well. Now that we retrospectively evaluate the X-ray, that you can see some sclerosis, which is not very obvious. In the early cases of transient osteoporosis of the hip, usually the X-rays are normal. This X-ray was reported as essentially normal, and then we moved on to the MRI, and this was a case of transient osteoporosis of the hip. This was a clear pass in all the aspects.
So this is the ultrasound static image of the unibladder, in which I can appreciate that there are multiple lobulated, well circumscribed areas which are arising from the lateral walls of the unibladder. The lower one appears echogenic, and it seems to be arising from its mural surface, because it is seen in the node-dependent portion. So I'm assuming that these are arising from its wall. So I will further confirm it on the Doppler imaging as well. So blood flow is seen, also seen in it. So I'm suspecting that these are the masses which are arising from the wall of the unibladder, which are suspicious for malignant etiology. So I will convey my findings to the referring physician and
Yeah.
and recommend CT, chest, abdominal, pelvis.
Generally, the malignant mass of the bladder usually involves one part. Here you see multiple lobulated masses. Of course,
Yes.
malignancy is one of the differentials, an important one too. Any other differential possibility in this case?
These are not hematomas because these are not in the dependent portion.
Of course, they are not
Um,
hematomas, I agree. Any other differential
okay.
possibility?
Then these could be any benign lesions which are
Like,
arising from the wall.
like what? Mm-hmm.
It could be papillomas, multiple papillomas which are well circumscribed,
What else could they
arising
be?
from the wall.
The patient is 50 years old, diabetic male.
Diabetic male. Any granulomatous uh, condition.
What
I
would you do
cannot
next?
appreciate thickening of the wall CT
What would
or
you do?
MRI, pelvis with contrast.
How would that help?
Yes, sir.
How would that help?
Um, uh, yes, the contrast will show its enhancement. So it will
Ultrasound is quite
clearly,
enough. We did evaluate the vascularity also, the masses. Even if they enhance, how would that help take this case further?
um,
Before recommending a CT and MRI, what would you recommend in this case?
kidney, ultrasound of the kidney
Good enough. Oh, good enough. You want to see
to
kidneys,
see.
and the kidneys were fine. Now, what would you do?
Yes. Cystoscopy.
You want to advise a cystoscopy in this case. Okay.
So this is the MRI sagittal image. T2 weighted image. First of all, I will scroll all the images and then I will convey my findings. So I can there is a prominent ventricular and extraventricular spaces which could be related to the patient age.
Yeah, the patient is old.
Cerebellum, there is a relative atrophy of the cerebellum is noted with hyperintense signals in it.
Good enough. Anything else?
And there is also atrophy of the midbrain noted, including
Agreed to
the
that also. Anything else?
okay. Hyperintense signals are also noted in the visualized thalmi bilateral, which I will confirm on the axial images as well. So this is the axial image T2 weighted. Okay. Yes, there is there is atrophy of the midbrain as well as of the pons at this level and giving the hot cross sign. And there is also cerebellar atrophy noted with prominent sulci. Okay. I'm now looking for the rest of the findings. No cerebral lesion is seen. No infarct or hemorrhage is noted. So on these imaging findings, my diagnosis is multisystem atrophy of the pons. I will inform the findings to the referring physician and correlate with the history of dementia.
There was a
And
history of
also
dementia.
correlate with the previous imaging.
Good
Yes.
enough.
Then it is the case of multisystem atrophy.
Madam, there are a few conditions that you need to know about. One is a leukoplakia, the other one is a malakoplakia.
Malakoplakia. Okay.
Both can involve the genitourinary system. Leukoplakia is pre-malignant condition, malakoplakia is not. All right?
Okay.
Yeah, so with the malakoplakia, the most common site of involvement in the genitourinary system is the urinary bladder. Okay? Number one.
Okay, sir.
Number two, with malakoplakia, you can see multiple masses like this. Okay?
Okay. Okay, sir.
You do want to scan the kidneys to see if you can find such lesions there on any other part of the genitourinary system. This was referred. See, you first want to confirm what this is. Of course, malignancy, I said, remains a differential possibility in this case. The first differential in anyone's mind would probably be a malignancy. So before recommending a CT or before recommend MRI of the pelvis wouldn't add anything here. CT in this case would add to a metastatic disease if you want to stage a malignancy. First, you would want to refer this patient to a urologist to do a cystoscopic biopsy of this lesion. All right.
Okay. Okay, sir.
And
Yes,
and
sir.
this turned out to be a malakoplakia. The patient was a 50-year-old diabetic who presented with urinary frequency urgency and hematuria. And both the differentials were given, and the patient then underwent a cystoscopic biopsy, and they turned out to be malakoplakia. You cannot definitely differentiate malignancy from this condition. Both remain the differential possibility. This is a pass case for me with a little bit of lack of knowledge here because you need to know other conditions other than malignancy which can involve bladder like this. Yeah, so read up on malakoplakia and leukoplakia too. All right.
Okay, sir. Okay, sir.
Yeah. With the second case, a clear pass. As simple as that.
Okay.
Yeah. All the
Thank you, sir.
findings were correct. Your communication skills are good, and so is everything. I intentionally showed you the sagittal, because if I had shown you the axial, you would have picked it up immediately. You told me about the atrophic changes in the cerebellum. You did talk about some abnormal signals in the brainstem, the pons, and then on the axial, you were bang on target. Yeah.
Yes, sir.
So this was a multi-system atrophy. A clear pass in the second case. All the very best, madam.
Thank you, sir. Okay.
So I have been presented with ultrasound images taken through linear probe. These are the grayscale images. I can see there is hyperechoic area noted uh, within the giving scan, which is surrounded by a thick hypoechoic um, area. It appears to be a slightly rounded to elongated
Mhm.
with the internal hypoechoic area within it. It appears to be within um, I think within the subcutaneous tissue.
No,
However, in my routine practice,
it's in the abdomen.
okay, so it's in the abdomen. It could be related to bowel loop. So in my routine practice, I will look through the whole set of the images. Um, so these are the um, again ultrasound images of the same patient, and again showing a hypoechoic area within it with surrounding hypoechoic wall. These are appears to be a kind of bowel loops which have a thickened wall with internal hypoechoic area. On the color Doppler, there is no significant vascularity seen within it. The wall of
These
the
indeed were the bowel loops. Okay, what do you think?
I think the wall of the bowel loops appears to be thickened,
Uh-huh.
um, with no vascularity seen within the wall. So I'm
Hmm.
thinking of this could be related to some ischemia within the bowel loop.
The patient
Um,
is 3 months old.
so in 3 month old with a ischemic bowel loops, I would be thinking of this could be related to some bowel ischemia in this patient could be related to some intersusception or necrotizing enterocolitis, least likely
Is
because it is
this intersusception, or could it be intersusception?
it is it could be it could be intersusception because of this hypoechoic area within this could be an area of transition point.
Hmm.
Like it could be a lymph nodes or in this scan it is I think giving a target appearance with no vascularity.
Here it shows the target or donut sign. Here it shows the pseudo kidney sign. What is against intersusception here?
So this is a case of I think ileocecal intersusception,
What is
which is
this?
usually this is a this is a I think ileum with an internal
Does this look
hypoechoic
like
nodule.
a, yeah, what this nodule could represent?
This could be a lymph node or this could be
Why was the vascularity shown?
vascularity was on the periphery, not within the lesion.
Yeah, so why was that color Doppler shown in this case?
Color Doppler was so to see whether the bowel loops are ischemic or non-ischemic.
What would you do next?
So this is an emergency condition. I will urgently inform my finding to the referring physician. This require urgent referral to a pediatric surgical team for urgent reduction. This can be done via pneumatic or hydrostatic reduction. However, pneumatic is most common,
Hmm.
like most better route for reduction in this
What are
patient.
the complications of intersusception? One is ischemia, the other would be
There is peritonitis, perforation.
perforation. So before referring this patient, you can evaluate perforation or ultrasound too.
Yes, okay, yes. Okay, so these are the axial slices of an abdomen. Um, Abdomen post contrast images, protovenous phase. I will have a quick look through the
whole set of the images before I comment my finding. So I just take a moment to go through the whole set of the scan. So as going down, I could see there's a large ascites is seen within the abdomen. There is also peritoneal. Oh, sorry. Okay. So there is also peritoneal enhancement is noted. The bowel loops in the lower abdomen appears normal. There is a significant mesenteric fat staining is seen. I can see some changes, a fat staining area within the anti-abdomen wall, which could suggest that could be due to previous surgical intervention.
Okay.
There is also some omental nodularity is seen within mesentery and omentum. I'm going to the top section to see. Okay, so liver appears to be the liver margin appears to be irregular. And I could find there is an lesion noted in the right lobe of the liver with it is appears to be multiloculated with peripheral calcification and there is adjacent fluid is seen in the subhepatic space. So I'm thinking this could be ruptured um, and which have lead to significant ascites and free fluid within the liver, or sorry,
Is
within
it
the abdomen.
is this arising from the liver or causing scalloping of the liver margins?
At some point, it is appears to be it is causing some scalloping of the liver. However, however, in my routine practice, I will look at the coronal section as well to further characterize it. Also, these are the coronal slices of the same patient. Okay, so I'm looking the area of the lesions, which is a calcified, and however, for calcification, I will confirm on the non-contrast CT to see whether it is a calcification.
This
For
was
its
a
origin,
calcification.
okay. So for its origin, I'm trying to see if whether it is the kidney appears to be normal. It is non seems to be arising from the kidney. This could be I'm looking at the adrenal gland. If it is arising from the adrenal, the left adrenal gland is normal.
Do you want to see the axial again?
Yes, I would like to see the axial again. Sorry. Yes. So the gallbladder itself appears normal. Um, I'm just want to see the adrenal gland is normal. So this is not arising from the
Kidney
this
or adrenal gland?
yes, and oh, this could be I'm looking for if this is arising from any bowel loop, which is not appears to be seems to be arising from the bowel loop. So this could be within the or within the peritoneum, which has ruptured, or
Mhm.
giving the multiloculated appearance and calcification. It appears to be in a hydrated cyst, uh, which has ruptured and leads to a peritonitis and omental thickening. However, the omental nodularity is concerning for some malignancy as well, but I could not
Will
find any
peritoneal
malignancy.
nodularity be present in hydrated doses?
If it is, it can lead to a peritonitis, then this could cause omental nodularity as well. Um,
So you think this is
Apart from,
hydrated arising from the peritoneum?
I'm not able to connect whether it is arising from
All right,
where.
I'll take that as a differential. Any other possibility?
Okay. The other differential for this could be a hepatic. Oh, sorry, it is not arising from the liver as well. Um,
What can cause a scalloping of the liver margins?
Yes, the pseudomixima peritoni with mucinous carcinoma
Of
of the appendix, bowel loop.
we're done. So this was your first case, right?
Yes, sir.
So this is a pseudo kidney sign, bowel within bowel appearance, and then you see a lymph node in it. Yeah. This was a case of
Yes, sir.
intersection. The vascularity is important to evaluate since your management depends on the vascularity too. Your prognosis also depends on the vascularity as well. Before referring the patient again, the important finding was to rule out perforation. Yes, is that important?
Yes, sir.
The perforation, if there is perforation present, will that change the management?
Yes, then the reduction would not be a better option. This will require a surgical intervention.
So there was a missing point here, wasn't it?
Yes, sir.
Yeah.
Yes,
So
sir.
so that these are the few small things that you need to practice. Yeah.
Mm.
So everything was fine with this case, except for one thing. Before referring this patient, you'd want to rule out perforation. You would want to go for an ultrasound in a young patient, and then according to that, you refer this patient if to a surgical unit for air reduction or open surgical management. Yes.
Yes, sir.
Yeah. With the second case, eventually you got it. No.
Yes.
This was a subhepatic mucinous adenocarcinoma of the appendix. And then you had mets in the liver too. Can you appreciate few?
Yes. No. Yeah. In the liver.
Calcified metastases can be from?
Can be from mucinous adenocarcinoma
Yeah.
of the.
Yeah, and there is a long list. So one of the differentials of a calcified metastases is a mucinous tumor. Yes, and all of this was pseudomyxoma peritoni with peritoneal
Oh,
nodularity, some dense ascites. It's denser than the simple ascites, don't you think?
yes, sir. It is denser. Yeah.
And then there is peritoneal thickening as well. So with both the cases, with the first case, I don't know if I'll give you a pass because you need to rule perforation out first. With the second case, you are a pass. This was a difficult case. You told me all the findings. You did well. You tried hard. It was a good attempt. But consider pseudomyxoma peritoni when you see the margins of the liver being scalloped. Yeah. So this case was a pass.
Okay, so this is lateral X-ray of the elbow joint in a skeletally mature patient. First of all, I'm just going through the image so I can see that there is elevation of the anterior fat pad, giving exhale sign. The posterior fat cell also visualized, so it is suggestive of joint effusion. Now I'm looking for the presence of any step in the head of the radius. So this line is, there is a lucent line, but I think this is projectional due to superimposition of the images.
Lucent line where?
And just at the mid part of the head of the radius, which is extending towards the capitulum. So I'm looking. So I will confirm on orthogonal view, and I'm just trying to trace the radius.
This is the orthogonal view.
Okay, so I'm just again tracing the head of the radius. Okay. So there is no step in the head of the radius. And yeah, so I'm looking at the humeral capitulum and trochlea. So there is no fracture or any lucent line which is crossing the trochlea or lateral or medial epicondyles. Now I'm looking at the ulna. So until now, I cannot find any lucent line or yeah. So I'm just going to check the soft tissues of the so there is slight increase in the soft tissue anterior to the joint. So I am suspecting soft tissue pathology, or this may be due to just projectional due
Patient
to
presented with trauma.
okay. So I'm looking again at the supracondylar region and the head of the radius. So there is slight ill definition of the head of the radius. So I'm suspecting head of the radius fracture. Otherwise, there is a joint fusion. So patient needs to be referred to the orthopedic clinic for further evaluation, because joint fusion sometimes associated with occult fracture. So further evaluation with MRI suggested to further evaluate this patient.
I have a CT of this case.
Okay. Okay, so I'm just going through the images first. First of all, I am just checking the, yeah, so here I can see that there is a lucent line which is projecting along the coronoid process of the ulna. And so this is the site of fracture with joint fusion. Patient needs to be managed conservatively, and immobilization is suggested in this case for further management, and orthopedic referral, fracture clinic referral depends upon the availability of the.
That line, that lucency that you saw on the X-ray was real.
Okay, yeah.
Yes. Can you tell me the terrible triad of elbow?
Terrible triad of elbow. There is, I guess, fracture of the coronoid process of the ulna with medial ligament injury, I guess.
No, it's elbow dislocation. It's elbow dislocation, elbow dislocation, radial head fracture,
okay.
coronoid process fracture.
Okay.
Yeah. We'll move on to your next case.
Okay, so these are axial T2 images of a patient. First of all, I'm just going through the images. Okay, so I'm just going through the images. I am trying to check any focal abnormality within the parenchyma, and there is no focal abnormality or hyperintense altered area which is present. So I'm just going to my review areas. I'm looking at the signal wide of the vessels. The superior sagittal sinus appears normal to me. I'm looking at the gray white matter. It seems to be normal. The middle anterior circulation also appear patent. I'm checking the cella. There is no obvious abnormality involving the cella. The temporal horns also appears unremarkable. And I'm looking at the posterior fossa structures. So until now, I cannot find any abnormality. So I'm going to check the orbits. Oops. So there is slight enlargement of the medial rectus muscle on the right side. So I'm just trying to check the clinical history of the patient, how the patient is presented.
Would you further characterize the medial rectus on the right side?
Okay. So there is altered signal with slightly iso-intense signal is seen, which is involving the medial rectus muscle with slight expansion of the muscle. And
muscle belly, the tendons are fine.
Yes, muscle, it is involving the muscle belly, with however the tendons are normal. There is also involvement of the left side of the right side of the lateral rectus. The similar changes are seen within the lateral rectus. Now I'm trying to look the inferior. Okay, I'm going opposite side, so I will check the inferior. So similar findings are seen within the all
Is
of
there
the
proptosis?
there is just going to the area of interest. Yeah, there is a small amount of proptosis also seen on the right side. So I just want to check whether the patient have any history of hyperparathyroidism or Graves' disease. So it may represent hyperparathyroidism as the insertion site is normal.
Your differential would in this case would be?
I'm just trying check for the presence of any effect like soft tissue changes in the right orbit
to rule out before
to rule out any inflammatory process, as I cannot see any fat stranding.
Okay.
So I will check correlate with the thyroid function test and further send the patient to the ophthalmology team for further management and to endocrinology team for the management of thyroid related disease.
Good enough. The important finding here was to pick up the posterior fat pad, and the anterior fat pad is also elevated. Yeah. Then you did talk about this lucency. You were not sure if this was real or an artifact, but then on the CT it did turn out to be a coronoid fracture. Just read up on the terrible triad of the elbow, which I did tell you. There's fracture of the coronoid process, then you have radial head fracture, and then there is elbow dislocation. So this was a clear pass. And you couldn't find any abnormality. Then you started your review areas, and eventually you observed the changes in the right eye. Yeah. So when you describe it, you need to, with your words, you need to tell the examiner what you're thinking of. Here you just spoke about the medial rectus being a little thickened, but you should have said the tendon's insertion appears to be fine. It demonstrates the Coke bottle appearance, I think it is called. So so that sign it is demonstrating, and then you see some proptosis. You also want the fat side sequences to rule out any inflammation, intra or extra-orbital inflammation, which in this case was not there. So this was a case of thyroid ophthalmopathy. Just a little refining is what I would say you need to do. But you're a pass on this case too. So both the cases are a pass. Well done. Thank you very much.